Hello everyone. I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will study a very important topic, that is asthma. And from asthma you will be asked a long question. So you have to study this topic in that manner. Asthma is basically a chronic inflammatory disease. What is acute and what is chronic? Something which is more of a duration, like that is more of 6 weeks of duration, then you will name it as chronic. Otherwise you will name it as acute. So there is the airway basically becomes hyper responsive. Just like when your mom left you home alone, so you became so responsible, right? Just like this, the airway also becomes hyper responsive to each and everything. Like when you are left alone in your home, what do? You become so suspicious, like even if the ant is moving, then you notice that where she is going, right? Then there is reversible airway obstruction. What is the epidemiology? It contributes to almost 300 million people worldwide. Common in children's, and most common form is the atopic asthma. Let's see what is the classification based on the etiology. The first one is you have the extrinsic and the intrinsic. In the extrinsic one, what happens? You have something called as a IgE. I have already told you the types of immunoglobulins that you have. So you have the IgE. They are basically triggered by your allergens. They are triggered by the allergens and they begins in the childhood. So what happens, like when there is some allergens or the, like say, pollens, so what happens, the patient becomes so hyper responsive. Some of the patient may start sneezing also, like they are allergic, and in the allergy E, so you have IgE. Okay, then next thing is the intrinsic one, that is the non-atopic one. It is no allergic. Sensitization is required, triggered by the immune stimuli, viral infections, and the air pollutants, right? Based on the clinical types, you have the allergic, non-allergic, and exercise induced. How can the exercise induced? Like some of the people, like I'm speaking right now, also I'm becoming very uh, induced then. So what happens is, when a person do a rigorous amount of exercise and he is not doing that exercise on a regular basis, so one day, on a very fine day, he decided that I should be fit, and on that day he did a running of 5 kilometers. As a result of which, what will happen, the person is not at all prepared for this environment, for this situation. His heart rate will become very fast and the person will become very responsive. Okay, here you have a triad called as your Samter's triad. Here you have a triad of asthma, nasal polyp, and aspirin sensitivity. So if this triad will asked in your MCQ exam, so you have to name it as the Samter's triad, first thing. Then based on the severity, you have the intermediate, mild, moderate, and severe, that we all know from our first year, right? What is the epidemiology and the risk factors? You have the genetic predisposition, like the interleukins, then you have the family history of allergy. Environmental factors. Next, viral infection. Air pollution, the main hero of everything, air pollution. Then cigarette smoke. See, in this respiratory chapter, cigarette smoking will be a hero everywhere. So if you are not able to recall the risk factors, remember cigarette smoking. What are the drugs which causes it? Are the aspirin we have seen in the SAM test triad, then you have the NSAIDs, then you have the beta blockers, and the others one are obesity. Obviously, if the person is obese, sometimes he will feel difficulty in breathing, right? Then GERD and stress and anxiety. When we are in stress, like how my voice is changing, right? We are not able to take a breath properly. Let's see the pathogenesis. I first time showing you this figure. This is the type 1 hypersensitivity reaction. There are genes and allergy which triggers it. Then there will be the expression. There will be the expression of T helper cells. Expression basically increases. And there is activation. Activation of what? Activation of B cells. As a result of which, what will happen? The B cells will activate the mast cells. Right? And the immune system of the person will get weakened. Right? See this. Firstly, there is trigger or exposure to allergens or infections, then the immune system gets activated. There is atopic asthma, that is, firstly there will be allergens that will come into the place, then they will produce the APCs, then there will be activation of the T helper cells that will release the cytokines. Now interleukin 4 is basically for the IgE production, interleukin 5 for the eosinophil, because I have told you that letter E comes at the 5th place. So interleukin 5 is for the eosinophil activation, interleukin 13 for the mucus production, and IgE binds to the mast cell for the sterilization. Next, you have as the mediators are released. What happens is you have histamine, the main hero. Histamine basically causes the bronchoconstriction, and the leukotrienes basically they are the potent bronchospasm. They causes the potent bronchospasm. Then you have the phases. First one that you have is the early phase reaction, which occurs in minutes. There is bronchospasm will be there, then mucus secretion will be there, vasodilation and edema, vasodilation and edema. Then this was the first phase. The second phase that you have is the late phase, that is for 4 to 8 hours. There will be the recruitment of neutrophils, and there will be T2 helper cells activation. T2 helper cell activation will be there. Next you have other chronic changes. There will be smooth muscle hypertrophy or hyperplasia that will be there. Subepithelial fibrosis will be there, and goblet cell hyperplasia will be there, which will increase the mucus level. Let's see what is the morphology. In the morphology, you will be seeing the hyperinflated lung. See this figure. Are you able to appreciate how the lungs are hyperinflated? Hyperinflammation means the lung will swell up, and then there will be mucus plug in the bronchi and the bronchioles. In the microscopy, you will be able to see the spirals that are the whorl mucus plugs. Then you will be able to appreciate a syndrome called as the Charcot-Leyden Crystals. They are basically eosinophilic crystals. Okay. What are the clinical features? The clinical features will be, there will be wheezing. Wheezing will be there. Then there will be dyspnea. After dyspnea, there will be cough. Cough can be either dry or productive. There is chest tightness. And there is hyperresonate. You know what? When you auscultate the chest, you have certain sounds. You have the sounds on the basis of their resonating capacity. So here they are hyperresonating chest. Okay. What are the complications? The complications will be, there will be status asthmaticus if the patient is having unremittent asthma attacks and is not responsive to the therapy, even on giving the drugs to the patient, his or her body is not responding to the drug, then he will end up to this complication. Second one you have is a respiratory failure. Third one will be pneumothorax, that is due to the alveolar rupture. If there will be alveolar rupture, there will be pneumothorax that will occur. Then you have the atelectasis. If there is chronic airway remodeling, which will fix the COPD. Investigations that we will do, first we will order the pulmonary function test. Decrease the in the pulmonary function test, you will be able to appreciate first one, there will be decrease in the FEV1, then there will be decrease in the FEV1 is to VC ratio, then there will be increase in the PEFR variability. Now peak expiratory flow rate is what? There will be the daily monitoring morning drip, you have to daily monitor it. Then you will order the blood test, and that you will be able to see the huge amount of eosinophils will be there, and increased serum IgA will be there. In the sputum, you will be able to see what? Curschmann spirals and Charcot-Leyden crystals. What is the treatment? For the treatment, you will give relievers like the short-acting beta-2 agonists like 𝗲𝗵𝗹𝗵𝗺 and terbutaline. Anticholinergics, then you will give the controllers to prevent the drugs, then you will give the inhaled corticosteroids, then the long-acting beta-2 agonist, and then you will give the what? 𝗖𝗵𝗵𝗴𝗺 like montelukast. What are the complications that can occur? The complications can be, if there is status as asthmaticus, it will lead to the respiratory failure. If there is airway remodeling, it leads to the irreversible obstruction. And if there can be pneumothorax, which is very rare, and at last everything is done, you will see that the patient is dead. Okay, so this was all about the asthma portion. Let's just revise what we have learned. We have learned that asthma is IgE mediated and it is chronic. The prevalence is more in males as compared to the females. Then you have smoking as a risk factor, very, very important. Air pollutants are also involved. Then if someone asks you about the pathogenesis, first you have to tell them that there is exposure to the antigens or the pollution that will be there, which activates the immune system, right? Clinical features are same for all the respiratory related disorders. So I guess we are done with this chapter, and if you are having any sort of doubt, please feel free to reach me. Please feel free to DM me. Thank you so much.